We're going to start in with cardiovascular disorders. If you want a more in-depth review of cardiovascular function, there is a link in the module to that. And there's also a couple links in the module to assessing vital signs if you want a review of that. We're going to go right into cardiovascular disorders and briefly talk about general cardiovascular function. But again, if you want a more in-depth review, check the Canvas module and see if that's going on. If you feel like you got it down with cardiovascular function, you know how it works, you don't have to look at that optional lecture. So taking into account the importance of the cardiovascular system in its function in our body, the cardiovascular disorders that we're going to talk about are some pretty important things we need to talk about. So learning objectives for this part of the lecture, to understand cardiovascular anatomy and blood flow. We'll talk about it briefly here, and then if you want a more in-depth, you can look at the other lecture. We're going to talk about vital sign assessment techniques. There are also two lectures linked in the module with details about vital sign assessments. So if you need a review of that, that's in there as well. We want to be able to identify risk factors and warning signs for cardiovascular disease just in general. And then when we talk about individual diseases, we'll talk about those specifically. And we want to apply that knowledge to clinical practice. Cardiovascular knowledge is critical for us as PTAs for lots of reasons. Cardiovascular conditions are the most prevalent causes of death worldwide. And 1 in 4 deaths in the United States is caused by heart disease. A lot of people have secondary cardiovascular involvement, even though they're coming in for something else, coming into PT. They don't just leave their cardiovascular disorders at home when they come into PT. So they bring that in too. So because cardiac conditions are so prevalent, many patients refer to physical therapy. Even if it's not the primary thing they're coming in for, they need to be assessed for cardiovascular function and monitored for vital signs during their treatment session. Even if their primary diagnosis involves a different body system, like they got a total knee replacement or rotator cuff repair, or it's orthopedic, they might have those cardiovascular diseases along with. So medications to control cardiovascular disease and associated signs and symptoms are widely prescribed. Lots of people are on cardiovascular medications, and they can affect a patient's performance in physical therapy. So it's extremely important for a PTA to understand various cardiovascular disorders and respond appropriately to situations involving problems with the cardiovascular system. So knowing the side effects of cardiac medications and how it might affect our therapy session is a very important part of our body of knowledge. We'll have a separate section on cardiovascular medications. So basically the systemic circulation pattern, the blood flow through the heart, deoxygenated blood returns to the heart from the superior and inferior vena cava and enters the right atrium. So that's our systemic circulation returning to the heart. From the right atrium, it flows through the tricuspid valve into the right ventricle. From the right ventricle, it flows through the pulmonary valve out of the heart through the pulmonary arteries to the lungs. So the pulmonary arteries carry the blood to the lungs where they get rid of their CO2 load and pick up oxygen. So they're exchanging their CO2 for oxygen, which is lovely. And then the pulmonary veins carry oxygenated blood back to the heart, and the oxygenated blood from the lungs enters through the left atrium. From the left atrium, the blood flows through the mitral valve and into the left ventricle. From the left ventricle, the blood flows through the aortic valve into the aorta and out to the body. So blood flow through the heart is achieved through the pumping mechanism and contraction and relaxation of the cardiac musculature and pressure gradients between the chambers of the heart. So blood always flows from an area of greater pressure to an area of lower pressure. So when the venous return comes into the right atrium, it stretches the right atrium so it has more pressure and it can pump that blood down into the right ventricle. So cardiac muscle contraction and pressure gradients, that's how it all happens. Again, we're back to physics and chemistry, right? It always comes back to that. So we have the pulmonary circulation, which is the blood circulating in the lungs, and we have the systemic circulation, which is the blood circulating in the body. And the heart is just pumping it all around. Good job, heart. We like that. We're going to assess heart rates most oftenly at the radial artery in the wrist. I think we all know how to do that. And if you don't feel confident with it, practice, 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 just like everything. Alternatively, you could also do a carotid pulse at the neck, brachial pulse in the upper arm, femoral pulse, or a dorsal pedal pulse. And we'll talk about different times when we might want to do those particular things. So normal values for heart rate, it's measured in beats per minute, adults 60 to 100. So if it's less than 60, it's bradycardia, and if it's greater than 100, it's tachycardia. Newborns have a higher heart rate. Their little heart is just pumping away in there. Once as they get older, the heart rate starts to go more towards normal adult values, just like with the respiratory rate. Interesting, right? So when we're assessing blood pressure, which of course we did last quarter in your 110 class, the primary method, we're going to use a sphygmomanometer and a stethoscope over the brachial artery. Alternative methods, a lot of clinics and inpatient facilities use automatic blood pressure monitors. And the clinic where I've worked for a long time, we had the automatic blood pressure monitors. We called them nurse on a stick. That's just what we called them. And the funny thing is, I'm old school, and so if I didn't like the number that I got with the automatic monitor, I would do a manual. So, or if there's some kind of error or something. So you should, even if you have automatic blood pressure monitors, something might go wrong. Maybe someone didn't charge it last time or someone, whatever. So you got to know how to do that manual. Sometimes you're going to take a blood pressure using the femoral artery pulse on the lower extremity. There is a method of assessing peripheral vascular disease, which is called the ankle brachial index, which is ABI. And it should be, if you take the blood pressure on the arm and on the ankle, it should be the same. And if there's a difference, if the blood pressure is lower at the ankle, it's indicative of peripheral artery disease. For normal values for adults, systolic blood pressure, which is the high number where our heart is contracting, should be between 90 and 120 millimeters of mercury. Diastolic, which is where the heart is relaxing and filling, should be between 60 and 80 millimeters of mercury. Children tend to have lower values than adults. That sort of makes sense. If you are in a situation where you're taking vitals on a child, get one of those age-specific charts so you are comparing it to the right numbers. We are going to assess our exercise rate by the rate of perceived exertion. There are other things that we might be doing while people are exercising, like oxygen saturation. The most common tool for assessing oxygen saturation is the pulse oximeter that we've done in lab. And the normal rates are 95 to 100. Pulse oximetry is not considered an exact science. There's a little bit of fluff in the numbers, and so it gives you a general. So lots of things can affect pulse oximetry, like decreased peripheral circulation, for example. So we're going to listen. We can listen to heart sounds with a stethoscope. Our normal sound is lub dub. That's what they call it. Lub dub, lub dub. If you hear a whoosh, it could mean a septal defect between the right and left sides of the heart, or a problem with a heart valve. So whooshing is not normal, but lub dubbing is normal. And we'll practice that in lab. Not this year, but next year. So the rate of perceived exertion scale, which is here, is a self-assessment scale. It's subjective. The patient measures their rate of perceived exertion. So it was originally developed by someone named Borg, and it's called the Borg scale. And it started out as being the 6 to 20 range. And the words work for a lot of people. There is a modified Borg scale that's a 1 to 10 scale, which for some reason people have an easier time with the 1 to 10 scale than the 6 to 20 scale. It kind of makes sense to me why people would have an easier time of that. But the heart rate correlation from the original Borg scale is the RPE times 10 is the approximate heart rate. So if you have an RPE of somewhat hard or 13, it approximately equates to beats per minute of 130. However, with the 1 to 10 scale, it doesn't equate. So it's a quick screening method, monitors exercise tolerance and guides treatment intensity. And for some cardiac medications, they artificially lower the heart rate. And so you have to use RPE because you can't use pulse rate as a reliable method to assess exertion. Okay. So there are all sorts of versions of the Berg out there, and some of them are a little bit humorous, like they have like what extremely hard you're running from a bear or something like that. So I don't know. I like funny stuff. That's just me. Other cardiovascular assessments, we talk about oxygen saturation. Normal is 95 to 100. Heart sounds with auscultation. We want to hear lub dub, not whoosh. Body weight. If somebody has heart failure, it's a concern if their body weight increases more than 2 to 3 pounds in a day or 5 pounds in a week. So if you weigh yourself every day, some people do, some people don't. You're going to notice little fluctuations, 1 or 2 pounds up and down. But if you gain more than 2 to 3 pounds in a day or 5 pounds in a week, that indicates fluid retention, particularly if you are currently experiencing heart failure. So body weight is a very good way to assess progress in heart failure. However, that can be a barrier for individual people. Some people with bad balance or other things have difficulty stepping up onto a scale. So let's not assume this is easy for everybody. The 6-minute walk test is a functional outcome measure. It's a functional capacity assessment. And basically, you measure the distance that somebody walks in 6 minutes. And we'll do that in our cardiopulmonary lab. And if they can't walk for 6 minutes, do a 2-minute walk test. Get a baseline and then compare to see if they're improving. An exercise stress test is usually performed either inpatient or at the cardiologist's office. It monitors your electrocardiogram, heart rate, and blood pressure during exercise and identifies exercise-induced problems. There's another version of the stress test that's more comprehensive, where they do imaging along with the stress test with nuclear medicine to assess myocardial perfusion and ejection fraction, which is really cool that they can do that. And the exercise stress test is kind of fun. If you've ever done it, you're running on a treadmill and they just keep making it harder and harder and harder. And they're monitoring all your vitals while you're doing it. And so people who can't do that, can't do the exercise stress test, they will artificially raise their heart rate with medications to get the same sort of measurements. It's way more fun if you can do it on the treadmill, though. Speaking as the patient. So, we know that there are cardiovascular risk factors that are modifiable and non-modifiable. Basically, you can't change your age. Your age is your age. And people like to say 60 is the new 30, but not where your cardiovascular system is concerned. So your risk of cardiovascular disease increases with age. Gender, 1 in 3 men and women die from heart disease. It's crazy, right? But the men have a greater risk of heart disease until women are postmenopausal, and then their risk for heart disease goes up and just is equal with men. So kind of not nice. So both men and women are at risk for developing heart disease, and 1 in 3 men and 1 in 3 women will die from heart disease. It's the most common cause of death among everybody in the United States. So ethnicity and heredity factors, genetic factors, and family history. There are some genetic conditions. There's one genetic condition that's called familial hypercholesterolemia that causes people to maintain high LDL levels and low HDL levels. So LDL is the low density lipoprotein, and HDL is the high density lipoprotein. And basically, LDL dumps fat into your arteries and LDL takes it out, or HDL takes it out. So one of my friends who was having a hard time remembering which was which, which was the good one and which was the bad one, her doctor told her LDL are the lousy lipoproteins and HDL are the happy lipoproteins. So however you remember it. But people who have familial hypercholesterolemia genes, without medical intervention, they're at a greater risk for heart attack and death in early age. Nice, right? There might be other familial conditions that put a person at risk, but it's difficult to identify true genetic links from cultural diets and activities. So there's something with sort of my age group of people that we like to think we're in control of everything. And that is one thing you're not in control of. Your genes are your genes. You pick your grandparents well because you're stuck with that. And eventually your genetics are going to catch up with you. So you can have the best, you can work on the modifiable risk factors all you want, and you're still going to have those non-modifiable risk factors. So the modifiable risk factors are smoking. I know smoking is a risk factor for everything. The chemicals in smoke damage the inside of your blood vessels, and the damaged areas attract fatty deposits, platelets, and other particles from the blood that can cause clotting. This decreases the interior lumen size of the vessels and makes the vessel stiff, causing greater peripheral resistance, and that makes the heart work harder. It's all connected. So smoking also damages the respiratory system, which is closely allied with the cardiovascular system. So newsflash, smoking's bad for you, right? Obesity is defined as a BMI of 30 or greater. Um, about a third of American adults are considered obese by this standard and are at risk for greater risk for cardiovascular disease and other health issues like diabetes and high cholesterol and triglycerides, all that good stuff. So, increased body mass makes the heart work harder. That's how it works. Diet. So, if you are at risk for heart disease, or you have high blood pressure, it's recommended that you decrease sodium, add potassium, depending on the medications that you're on. There's some medications that are incompatible with potassium. But in the case of hypertension, sodium attracts water. So extra sodium in the blood pulls water from the interstitial spaces and into the bloodstream. And it increases blood volume, causing greater pressure inside the blood vessels. So don't do that. So, tone it down on the sodium. That's easy, right? And watch your sodium potassium balance. So if you are at risk for heart disease, you should get that checked every now and then, like, once a year. Your exercise habits are super important. The heart is a muscle that needs to be exercised, and regular exercise increases cardiac stroke volume, decreases heart rate and blood pressure. When the blood is actively moving through the circulatory system because your heart's pumping away, like when you're exercising, it is less likely to pool in your extremities. Isn't that lovely? So if your blood is stagnant, it's prone to forming clots, thrombi. Lack of physical activity is associated with increased body mass index, hypertension, obesity, which are all associated with increased cardiovascular risk. So exercise, love it, gotta love it. So when a couple of years ago, I did an exercise stress test on the treadmill with the imaging, which was cool. So I got to see my ejection fraction. And when I was at the top exertion, my ejection fraction was 92%. And I'm like, go heart. That just shows you like a lifetime of exercising does your heart good. Sleep researchers found that sleep issues, especially not sleeping enough or obstructive sleep apnea or insomnia, can influence the risk of obesity, high blood pressure, type 2 diabetes, stroke, coronary heart disease, and overall cardiovascular disease. Obstructive sleep apnea can cause cardiac hypertrophy. For more information on sleep, there are articles linked in the textbook, which is so interesting. We talk about sleep quality with our patients a lot. That is a part of patient education that we can talk about. Sleep hygiene, it affects pain levels, it affects cardiovascular risk, it affects a lot of other things. So sleep is big. And you think, well, I don't really have that much control over that. Yes, you do. We can educate our patients about sleep hygiene. So, blood pressure control, if the heart has to pump blood through vessels that are narrowed and constricted due to hypertension, the heart has to work harder. And that can lead to cardiac hypertrophy, or particularly hypertrophy of the left ventricle, and eventually end in left-sided heart failure. High blood pressure is a cardiovascular issue in and of itself, but a person who has elevated blood pressure is at risk for lots of other cardiovascular disorders. So they call blood pressure the silent killer, because you don't know that your blood pressure is high unless somebody takes it. And it can influence increase your risk for coronary artery disease, heart attack, and heart failure. None of those are good. Diabetes is usually associated with atherosclerosis and heart disease. The extra glucose in the blood causes the blood to be more sluggish, move more slowly, and it makes the cellular components of blood stickier, if you want to think of it that way. So the vessel walls can become thicker and stiffer, and it's easier to form a thrombus clot, and that's never good. Cholesterol levels, your high levels of low density lipoproteins and low levels of high density lipoproteins are linked to cardiovascular disease. So when you have extra fatty substances in your arteries, it can damage the inner lining of arterial walls. In the little introductory lecture, which you may or may not have listened to, there's a photograph of the inside of a healthy artery and the inside of a damaged artery, and it's scary. Let me tell you. So the HDLs are thought to adhere to the LDLs and carry them to the liver for processing and removal. Isn't that lovely? Controlling your stress level is really important for avoiding cardiovascular risk. There is a correlation between stress and cardiovascular disease. It's not clear what that correlation is, but stress can lead you to unhealthy lifestyle choices, which are associated with hypertension and vascular damage. So some people, when they're stressed out, they drink alcohol or they smoke, they make less healthy food choices maybe, and have trouble sleeping. Or they don't have time to work out, so their activity level decreases. So all of these can lead to cardiovascular problems. So stress can lead to other bad things. Drinking too much alcohol can damage the blood vessels, liver, and kidneys. I just, a couple weeks ago, went to a webinar about with a registered dietitian, talking about a lot of different things, but one of the things they were talking about is that if you have high blood pressure, the Mediterranean diet is recommended by a lot of registered dietitians as a good model. There's also something that's called the DASH diet, and it's dietary activities to stop hypertension. And the DASH diet is sort of like an Americanized version of the Mediterranean diet. So in the Mediterranean diet, you're allowed to drink wine, or well, I guess you're always allowed to drink wine, but the registered dietitian said if you don't want to drink alcohol, you can drink grape juice or you can drink tart cherry juice or something like that, and it has the same effect that the wine has, the positive effect. So it's good to know. I'm gonna go get myself some tart cherry juice. So critical modifiable risk factors: smoking, don't do it. Obesity, work on that. Diet, work on it with the obesity. Exercise, yes, we love exercise. So these are 4 things that you can modify that are going to have a big effect on cardiovascular health. So medical conditions that increase your cardiovascular risk include hypertension, diabetes, high cholesterol, and sleep disorders. And I talked about some of those already, but here's kind of the little chart, because I love a good chart. Warning signs of cardiovascular disorders: vital sign changes. So if someone's heart rate or blood pressure changes, depending on what the stimulus is, that can be a warning sign. Shortness of breath or difficulty breathing, that's a problem. Physical signs like edema in the feet and ankles, cyanosis, you're blue, or sweating for no reason. And they call that diaphoresis, also sweating. Pain patterns, if somebody has chest pain or arm, neck, or jaw pain, it can be indicative of myocardial infarction. Neurological symptoms like dizziness, lightheadedness, and syncope, which is fainting, can be indicative of cardiovascular problems. So if your left ventricle is fibrillating and it's having difficult with cardiac output, that can make you dizzy and lightheaded, and it can make you faint from cardiovascular shock. Cardiogenic shock. In general, fatigue, sudden weight gain, like for no reason, like you didn't change your diet and all of a sudden your weight is up, that be indicative of fluid retention. And visible fluid retention, like you see edema in your legs or feet, or someone who's not ambulatory, edema in their sacral area is often shows up as a warning sign of increasing heart failure. So for PTAs, think about the signs. They can be subtle in the early stages. So a lot of times people look back when they get diagnosed with something, they look back and they go, yeah, I remember that time when we were walking up that hill and I could barely make it. We had to stop and call a cab or whatever. Um, they don't see it as a sign early on, but later on, looking back, they go, that was probably a sign of I was getting into heart failure. So our pre-treatment assessment before anybody who is on cardiovascular meds or has cardiovascular diagnoses, we need to do a thorough pre-treatment assessment, review their medical history thoroughly. You can do that before they get there. Check for cardiac medications, establish baseline vital signs. So a lot of times the PT does this at the initial evaluation, but you want to take them at the beginning of the session to make sure that's where they are today and how are they going to react to today's session. And you want to note any previous cardiovascular events. A lot of times if people have had cardiovascular events, I will ask them, have you been cleared by your physician to participate in exercise, that kind of thing. During the treatment, you want to monitor vital signs regularly to see how patients are responding to the interventions you're doing. You want to watch for subjective complaints like difficulty breathing, or people will tell you that it feels like their heart's racing. Observe for objective signs. Are they turning blue? Are they turning white? Are they turning red? Do they have edema in their extremities? You want to modify the intensity as needed, depending on how the patient is doing that day. So the key thing to think about is a good PTA pays attention to both subjective reports and objective signs. So we can act quickly when cardiac problems are suspected. So it's not just what the patient tells you, it's what you observe as well, but the combination of the two. So when do we want to take action? Um, Immediate concerns where we're going to stop treatment and assess. We're probably going to do another set of vitals. Someone reports chest pain or pressure, stop. Severe shortness of breath, another stop. Dizziness or syncope. Sudden changes in heart rate or blood pressure. Profuse sweating without exertion. If somebody's just sitting there and they start to sweat, that's a problem, potentially. If they start to turn blue, then they're not getting enough oxygen. So what we want to do is stop activity immediately, position the patient comfortably, reassess their vitals, stay with the patient, and then call for help if needed. So if they have chest pain or other symptoms, and we'll talk about when we talk about myocardial infarction, um, calling 911 is a good thing. If they have a loss of consciousness, severe difficulty breathing, or any doubt about the severity of their symptoms, it's a lot of times when I've had to call 911 in the outpatient clinic, when you're in inpatient, usually you're going to call the nursing team. You're not going to call 911. And if they have loss of consciousness, you're probably going to call a code blue. But when you're in the outpatient clinic, the times when I've had to call, I've said to the patient, I think we should call 911. And some of them say, yeah, go ahead and do it. Some of them say, are you sure? And you kind of have to talk them into it. And one lady said, well, could you call my doctor's office and ask them if they want you to do that? And I said, sure. So I called the doctor's office and I would talk to the nurse that was in charge of this patient. And they said, what's your plan? What do you want to do? I said, I want to call 911, but she told me to call you first. And she goes, "Do you want me to tell you to call 911?" And I said, "Yes." And she goes, "Okay, call 911." So I did. And they came and everything was good. But you know, look at those signs, pay attention. Cardiovascular medications. So I have a little lecture section where we're going to talk a little bit more in detail. There's a great little thing in the book where it has a bunch of different medication names, and you have to say whether it's a beta blocker, an ACE inhibitor, or a diuretic, what it is. And a lot of times you can tell by the suffix of the name. So beta blockers lower heart rate and blood pressure. Some people are on it for blood pressure, some people are on it for other things. They limit your heart rate response to exercise, and so you're going to use rate of perceived exertion instead of target heart rate. So ACE inhibitors can, one of the things that you might see in therapy is it might cause dizziness with position changes. They might exhibit signs of orthostatic hypotension. With diuretics, it might cause them to be dehydrated or mess up their electrolyte imbalance. And so you're going to watch for weakness or dizziness. The other thing with diuretics is, especially if the patient is on a recently increased dosage of diuretics or a newly prescribed diuretic, they might have to go to the bathroom more. And if you have someone with limited mobility, plan for that. So, how long is it going to take them to get to the bathroom? Anticoagulants prevent blood clotting, but they also increase bleeding risk. So you want to use caution with any manual techniques that you're doing, and you want to use extreme caution to avoid the risk of falling. Always review the patient's medications before treatment and understand how they might affect patient responses to therapy. So, any questions that show up on the board exam about cardiovascular medications are usually going to be with regard to that. How is this going to affect the patient's response to therapy? And so, in the section on the specific section on cardiovascular medication, we'll talk more about the specific names of them. So, main thing, assessment is critical. Monitor everybody's vital signs, regardless of their primary diagnosis. Know the warning signs. Early recognition can be life-saving, so you should trust your clinical judgment. Be aware of modifiable and non-modifiable risk factors, and you can educate your patient on that. And know when to stop and assess and when to call for help. Um, Cardiovascular conditions affect 1 in 4 Americans. That's everybody. That's so many people. Your knowledge and vigilance as a PTA can make the difference in patient safety and outcomes, and that is what we want.